Please note Madam's suggestions.
We are live now, ma'am.
Yeah, we can start because Madam has to go to another one.
Yeah, that is what. You can start fast and we'll have Madam's speech first.
Okay, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, Amogs Emergency Obstetrics Committee with Gujarat Societies, Himant Nagar, Bharuch, Anand, Nadia, and Surat. So it's my privilege to introduce the embassy of today's webinar, Dr. Sarfaraz sir. Sir is a consultant gynecologist, endoscopist, specialist from 20 years, and sir is currently the president of Himmat Nagar Obstetrics Society from 24 to 26. I welcome you, sir. And it's my privilege to introduce Dr. Ketan Vyas, sir. Sir is the consultant director, Sevak Maternity and Surgical Hospital, Ahmedabad. And the sir has received many awards and appreciation from Gujarat University and Foxy.
I think.
Yes, I welcome
Sorry
you,
to
sir.
interrupt you, Saiti. Straight away you hand over to Dr. Archana, please.
Okay,
Let
ma'am.
Archana introduce Madam Sunita Tandukar. I think
Okay,
we
ma'am.
skip all these introductions. Ours, we can have it later.
Okay.
So, Archana, you
Yeah,
can
thank
speak.
you.
Thank you so much. With folded hands and a warm welcome to everybody, dignitaries out here on this platform. I think COVID has given this best opportunity to connect everybody pan-India, even internationally, seeing everybody so with fresh over here to start up with this Amogs, another webinar. I welcome you all for this session of another session of emergency obstetrics, which has been conducted by Dr. Sneha Buyar, madam. So before we start, a little prayer from our side. And Saiti, can you play the prayer without wasting much time?
Sankurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam dhanasampadam Shatrubuddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam.
Thank you. It is my proud privilege to introduce our chief guest for today, Dr. Sunita ma'am. I think one word would describe her: very hardworking, fresh, and always ready to do something novel, and very, very cooperative to all the young brigade and everybody whosoever looks towards her for any opinion. She is president-elect for upcoming year and head of department chief IVF Endoscopy Center, Ruby Hall Clinic, Pune. Advisor and consultant of D.Y. Patil IVF and Endoscopy Center, Pune. Founder and medical director, Solo Clinic IVF, a center for excellence in infertility, Pune. She's also founder and medical director, Solo Stem Cells, a stem cell research and application center in Pune. Extraordinary achievements, India's first stem cell baby.
Thank you.
Yeah, thank you, ma'am. And we are so proud to have you here as our chief guest. Please, a few words of wisdom from you would take us to
Thank you. Thank you. See, first of all, let me thank Sneha, Archana, and your entire team for having me. It's always honor and a great privilege to be with Amogs and Gujarat, so many beautiful societies. I'm so close to every one of them, Himmatnagar, Bharuch, Anand, Nadia, Surat. All of these societies, they have treated me like a younger sister. And I'm always, it's wonderful to see Sudhir Bhai, Deepak Bhai, and Mahendra Soni Madam, sir, and every one of you. Ashwath, my dear friend, no one will leave you. Huh? I'm so glad to see you over here. And also Kazi sir, fantastic to see you all. When it comes to organizing the webinar and the conferences, the way Sneha works, I think Sneha is an asset to any organization. I have closely observed her for last more than a decade. And any responsibility you give, any conferences she organizes, she does it with meticulousness. And I am sure Foxy has given many awards to her for her various roles. And now she is going for the vice president post. I missed her in my tenure, but I'm sure one of the legends of Foxy will have her as a vice president. My wishes are always there with you. This time from Gujarat, two smart girls are entering, Sejal Nayak and Archana Dwivedi. Both are dynamic. They are known to do. See, Foxy also need people who will take the organization to yet another level. So I'm so glad that the young, like-minded girls are joining the Foxy, and I'm sure together they all will do very good job. Coming to your topics which you have chosen today, I'm so glad to see even Dr. Nitin Raitha. I don't know how you pronounce Nitin sir, but I came to Anand and I had a meeting with you all, and I will never forget that lovely evening we had with you. Mahesh Gupta speaking on cesarean myomectomy, and Sneha, you yourself taking a panel discussion on APH. I think whatever the webinars we have, every webinar gives us 1, 2 carry-home messages. So it's always wise to attend as and when you get the time. Also, Archana Munjal, I forgot to talk about him. He's not in Foxy, but I know his academic talent, and he is being pulled in my Foxy various programs. Sudhir Bhai and Deepak Bhai will take all of us to Kashmir, and I hope on 31st May, when they finish their Amritsar program, they have promised me they will start roping in the Kashmir program. And I invite entire Sogog, invite entire Amogs to Kashmir in April. Let's have a great conference under these two leaders, and who is joined by the leader of the leader, Dr. Narendra Malhotra. So thank you so much for having me with you all. And I will be coming to Gujarat again and again, either on webinar or on a physical format. Thank you so much for with me for some time. Thank you.
Thank you so much for your kind words, madam. They are
so much,
very
madam.
motivating for all of us, we know. Yes, Neha ma'am, you were saying something?
No, I just wanted to thank Madam for, of course, joining the program as a chief guest, and of course, praising me all the time. I hope I fulfill and I reach up to her expectations. So thank you so much, Madam, for your precious words.
Thank you. Thank you. Hi, Mahesh Bhai. Thank you. Unfortunately, Madhuri Patel is calling, so I just joined there, if you don't mind. And I'll be back with you all by the time you start your academic.
Thank you so
No
much.
problem.
Thank
Madam.
you.
Thank you.
Thank you. Thank you. Bye.
So, taking the program further, I would like to invite our guest of honors for today, Dr. Sudhir Shah sir. Sneha madam, would you like to do the honors?
Yeah, I would just, first of all, I would like to welcome everyone first. A very good evening to all of you. Myself, Dr. Sneha Bhuyar, the chairperson of Amogs Emergency Obstetrics Committee, along with my team, Amogs, Dr. Kiran Kurtakoti, the president, Dr. Bipin Pandit, the secretary, and of course, Dr. Rajendra Singh Pardesi, the immediate past president of Amogs. I welcome all of you. Chief guest, we have already heard Dr. Sunita Tandurkar, madam, and we're going to listen to the guest of honor, Dr. Deepak Bagre sir and Dr. Sudhir Shah sir. Of course, I'm very, fortunate to have the special guest, Dr. Ashwath Kumar, who has been very inspiring and with whom we have worked as, he was a vice president. So Dr. Ashwath Kumar and Dr. Nitin Raitata, I welcome both of you. The topics, as all of you know, Mahesh Bhai is always so, he's so inspiring that he definitely we have to change the trends what we have been following for especially in cases of placenta accreta spectrum. It was amazing to listen to him and watch his various videos what he has presented in the last few talks for which I have invited him. So welcome Dr. Mahesh Bhai for the talk as well as to the program. I welcome my expert, Dr. Vidya Tobi, and of course, all the panelists, Dr. Sujat Wali, Dr. Ashok Patel, Dr. Palak Kapadia, Dr. Falguni Thakkar, Dr. Rakhi Patel, Dr. Ruby Bhattacharya, Dr. Pinky Kataria, Dr. Shilpi Rawal, and of course, the lovely friends, young friends, Dr. Sarfraz Kazi and Kirtan Vyas, who was my committee member, Munjal and Archana. It's always a pleasure to have along with me, and of course, I thank the entire Gujarat societies and specifically these four societies: Himmatnagar, Bharuch, Anand, Nadiad, and Surat, the five societies. So, with this, I would like to, have the blessings of my mentors, advisors, Dr. Sudhir Shah, whom all of us respect a lot. Sir is a very senior consultant at Manan Hospital, Rajkot, and ex-assistant professor of Gynae, Baroda Medical College. He has authored almost 7 books on various gynecological subjects, and he's a past president of Rajkot Society. So we are very eager to listen to your precious words, sir, and have your blessings. So over to you, Dr. Sudhir Shah, sir.
Thank you, Sneha. It's a privilege for me to be here this evening with the stalwarts of the Foxes. And this is a very good activity by Amogs on this orthopedic emergencies. And I wish all the best to all the speakers. And out of box, let me tell you that we are all working for the Foxy, and we see that the Foxy should reach to the upper level. And our own colleague Sneha is there for the vice presidentship. I request all of you to canvass for her, and Archana is for the medical midlife management chairpersons, and we all are with you. And again, I wish you all the best, and I request the Archana to carry on the.
Thank you, sir.
so much.
Thank you
Thank
so
you so
much.
much for the wishes, sir. We can have a few words from Deepa Bhagde, sir.
Yes. Again, it's my pride and privilege to welcome sir. He has held many positions. You can see head of department of MP Shah Medical College, Jamnagar, and scientific committee chairperson, Gujarat State Gynecology Conference, of course, president of Jamnagar Society, and of course, he's got various accolades as well. So it is, indeed a pleasure to have you as guest of honor, sir. We are very eager to listen to your precious words as well.
Sneha, am I audible? Yeah, okay, fine. I mean, it's so good to see the energetic people here and how you get the energy, Sneha and Archana, Ashwat I see, Mahesh I see. Everyone is such abundance of energy. I mean, if I have to attend one webinar a day, I'm tired. One webinar probably in a month or so, I said, why me of all the people? But looking at your interest, your enthusiasm, I'm sure. I mean, whatever you post your wife for, it should be yours. Archana, I also wish you all the best for your midlife committee. Ashwat, you complete your tenure, but still, there is one more post for you to carry on, and we wish to see you as Foxy President in one of these days also. Mahesh, as always, you will find a great person to teach you PPH. Nitin, my friend, is also there. Mahendra Soni, my batchmate from Ahmedabad. So, Kirtan, Munjal, this is the whole team, Sneha, you gathered, who are friends, colleagues. But yes, talking about you now, in the sense, frankly, I don't know how you missed the bus last year. It has been a surprise to most of us. But anyway, that will teach you lots of lessons. You will know lots of new friends, miss some of them. But at the end of the day, I'm sure the God, the prayers, and your own hard work is going to take you to a greater heights. All the best, Neha, to you, and all the best to the emergency obstetrics session further up. Thank you.
Thank you so much, sir. Thank you. Your blessings and guidance is always very, very precious for me, and I'm going to follow the suggestions also. Thank you so much. I can see Dr. Rajendra Singh Pardesi, the immediate past president of Amogs, and I welcome sir. All of you know him as past vice president of Foxy as well, and you know about his lots of academic accolades, almost 28 paper presentations and
Yes,
so
okay.
many others.
Yeah,
So
thank you.
it's very, I'm very eager to listen to your speech and have your blessing, sir. Dr. Rajendra Singh Pardesi.
Thank you, Dr. Sneha. Respected chief guest, our Iron Lady, Dr. Sunita Tanwarkar, ma'am, and guest of honors, our friends of friends, and friends of all, Dr. Sudhir Shah, sir, Dr. Deepak Bagade, sir, and our Amogs president, Dr. Kiran Kurtakoti, and office bearer, and our special guest, Dr. Ashwath and Dr. Nitin Rai Thatta. So thank you, Sneha. Because of you only, our friend, I can meet Dr. Bagade and Dr. Sudhir, sir. So this is a really nice virtual platform, so we can meet each other. So first, I wish to congratulate Dr. Sneha Boyar for organizing this webinar with Himmatnagar, Bharuch, Anand, Nadiad, and Surat societies. Dr. Sneha has chosen nice topics on CS myomectomy and APH, and which are really important for day-to-day practice. And with the galaxy of speakers, chairpersons, and panelists, I think this is going to be a great webinar. I wish every success to Dr. Sneha Boyar and Dr. Vidya Thoppi for their future endeavor in Foxy as Vice President Foxy. I wish every success to Dr. Archana Dwivedi for her success as Chairperson of Midlife Management Committee. Thank you so much for inviting me. Thank you so much.
Thank you, sir. Thank you for the kind words, sir. Thank you so much.
Thank you, sir. Thank you so much.
Ashwath, sir.
Now we invite our special guest, Dr. Ashwath Kumar, whom I have just described, extraordinarily talented personality, yet so humble. He was the vice president when we were the chairperson, and of course he was a Foxy Quiz Committee chairperson. I have worked him, extensively with, especially when we had organized a PG program, especially the conference, and lots of postgraduates who have presented papers in more than thousands in number. So I'm really happy to have you, Ashwath, and definitely eager to listen to your words. Over to you. Please unmute yourself, Ashwath. Please unmute. Yeah.
Can you hear me, madam, now? Yes. It's always a great privilege to be invited among the doyens in the field of obstetrics in Foxy. So thank you, Amogs, Emergency Obstetric Committee, and thank you all the Gujarat societies for making me a part of this program. So I have to thank mainly Sneha Boyar madam, who invited me for this program. I congratulate madam for such a wonderful program, which is a need of our emergency obstetrics. So, and I am seeing sort of senior people, Pardeshi sir, Kiran sir is not there, I think. Anyway, thank you, sir. Then our chief guest, Sunita madam, always vibrant, our next president, Foxy. Then we have the real friends of friends and friends of Foxy, the senior Sudhir Shah sir and Deepak Bagde, the real give the real meaning for friends in Foxy. So both of them so close to me, and they used to encourage juniors like me so much. Then Nitin. And surprisingly, all are my friends actually, because Neha madam, you don't know that I studied in Ahmedabad. So I have worked with all of them, and it is like you are calling me back to my home. So that is my feeling here today. So that is why I told I will definitely come. Mahesh Gupta sir, I can have Kasi, Munjal, Kirtan. We all are in the contemporaries in different ways. Just all are. So it's like we are all. Dr. Archana is also here. So thank you everybody. And today it's a wonderful topic actually. And I would love to hear from Mahesh Gupta sir about cesarean myomectomy. That is why previously in our time, many times we were afraid to do anything with the myoma, or just take out the baby, close it and keep it down. Close the uterus, abdomen, and we leave the myoma there. We were afraid to touch the myoma. I know that Mahesh Gupta sir has changed so many things in obstetrics, and so many changes he has made. And I love his surgeries actually. So we will be listening to him today and his innovations. So innovations will be there, how to do myomectomy during cesarean. And yourself and with expert Vidya Tobi, you're conducting a panel on antepartum hemorrhage, which is also another. So here are two important topics which are very needed. So those listeners hope that they will be all listening to it and they will be taking home with lot of points. And again, before ending, I wish all the best for both of you. Neha madam, this time I hope that definitely I will see you as Vice President of Foxy, and for Chairperson of the Midlife Committee, I would like to have our support Archana madam, and both of them, you are the future of Foxy, so you have to be.
Thank you so much, Ashwath. And I think the connection, we've lost him. So I welcome Dr. Nitin Raitata, who is a special guest for today's program. So he's the professor of Obsgani in Pramukh Goswami Medical College, Anand, and of course PG and PhD guide, and he's a master trainer for emergency obstetrics. So who else can be the best special guest than you, Dr. Nitin Raitata? We are eager to listen to your precious words. Over to you, Doctor. Is he there? Archana?
Yes, he's there, he's there. Dr. Nitin sir, please unmute yourself. Should I call him?
Yeah, please call him. Otherwise, by the time I just recognize respected Dr. Mahendra Soni sir also, I can see we're very eager to, we're very happy to have you, sir. And thanks for your blessings always. Looking forward for your support also. So I think Dr. Nitin is here. Just a moment, and if he can speak, otherwise I just thank all of you for being here, gracing the program and blessing all of us. Thank you so much, everybody, for gracing this program. Otherwise, if sir is not available, we can go ahead with the academic session straight away. Once he joins, we can have his verse.
Yes, he's not picking up, so
Okay. Thank you. Over to you, Archana.
Yeah, thank you so much for the blessings. We move on to the first session with Dr. Mahesh Gupta sir and chairpersons Dr. Mahendra Soni sir and Dr. Ashwin Vachani sir. And I would like Dr. Kazi to take over from here.
Yes, ma'am.
It's actually my proud privilege to have Dr. Munjal also with me, and listening to Dr. Mahesh Gupta sir is itself art of surgery, which mesmerizing things. We tend to learn so many things. So Kazi, please introduce our chairpersons for the next session. Thank you.
Yes, ma'am. Am I audible?
Yes, you are audible. Please go ahead.
Okay. First of all, good evening, everybody.
Always audible.
Thank you, sir. Good evening, everybody, and thanks a lot to Dr. Sneha ma'am, Dr. Asna ma'am, and all the team of this Amogs committee. Nice to see all the stalwarts here. Already we have introduced everyone, so my job is to introduce Dr. Mahendra Soni sir and Dr. Ashwin Vachani sir, who are the chairperson for the first topic of cesarean myomectomy, which has been taken by none other than Dr. Mahesh Gupta sir. Our first chairperson, Dr. Mahendra Soni sir, a father-like personality for me. Every time he is with me in all my work, whether it is academic or whether it is social. He is the founder president of Himmatnagar, and he is the only person who is the second time becoming the Sobok president. And he worked since last 1981 at Himmatnagar, and he has done so many academic activities at Himmatnagar. He is also attached with so many clubs like Rotary clubs and everywhere. And he has also attended so many national and international conferences. Our second chairperson is Dr. Ashwin Vachani, sir. He is a professor and head of the department of Smimer Surat Medical College. And he was the past president of Surat of OBGYN Society also. The most important thing is he's the master trainer for emergency OC project run by Foxy GOI, and his special interest is in everywhere: emergency obstetric care, urogynecology, gynec oncology, everywhere. He also published so many national and international journals. So over to you, Dr. Mahendra Soni, sir. I invite you to introduce our first speaker. Dr.
Sir,
Soni, sir.
Please unmute yourself.
unmute कीजिए. Please unmute yourself.
Dr. Soni, sir. Unmute करो, unmute. नीचे म्यूट નું બટન છે ને?
Actually, he has done it actually previously. Just gentle.
Saiti, can you help us in this? Please unmute Dr. Mahendra Soni.
Actually, I have given request to sir to unmute.
He's
Hello.
unmute. Yeah.
Hello.
Yeah. Yes.
Hello.
Yes, sir.
Now I'm audible, right? Because
Yes,
there
sir.
was message that host had made me unmute. Okay, so I welcome all the chief guest of honor, and now it's my pleasure to introduce my very good friend, Dr. Mahesh Gupta, who is a main speaker for today's subject. I would like to introduce Dr. Mahesh Bhai. So he received 2 medals in 1993 in Gujarat University. He received Times of India Health Icon Award, and he's developed, patented, and published a technique to control. We all know that as COMOC. So every obstetrician has heard him on COMOC. He is having American patent also for this, having 50-bed multi-specialty hospital in Ahmedabad. Is an editorial board member in World Journal of Anemia. Is a ex-president of Ahmedabad Obstetric and Gynec Society and ex-honorary convener of Gujarat State Gynec Association. Invited as a guest faculty across India and abroad. So I will not take much time, and I will request Dr. Mahesh Gupta to start his lecture. Thank you.
Thank you, Mahendra Bhai. When Mahendra Bhai entered in MBBS, pass out MBBS, I entered MBBS.
Yes.
And we both did a post-graduation from same unit.
Same teacher.
Yeah, same teacher. So today's, am I audible well, Sneha?
Yes.
Yes, sir.
Yeah. So
Yes.
at the outset, I wish all the best for you and Dr. Archana for your forthcoming election in the Foxy,
Thank you.
and
Thank
all
you.
the very best for that. And in presence of all these, my seniors from Gujarat, Bagde, Sudhir, Shah, and Mahendra Bhai, and all my junior colleague Kaji, Munjal, and Kirtan, and another chairperson Ashwin. It's my privilege to share my views regarding the cesarean myomectomy. Actually, I hate preparing a postgraduate kind of PPT, like what is the incidence of myomectomy, what is the etiology of myomectomy, what are the location of myomectomy. So I will not do that because all are practitioners. So I will straight away go for my small compilation I have taken from my video library. So I take 3 or 4 cases. But before a decade, the cesarean myomectomy was abandoned by most of the surgeons and most of the organizations. That cesarean myomectomy should not be done, otherwise it causes a massive hemorrhage. It can lead to the obstetric hysterectomy. Then
Sorry,
later,
Mahesh sir, sorry,
Yeah.
Sorry to interrupt you. I think your screen is not seen completely. That slide, no? It is.
Yeah.
No, ma'am, we can see it. Sir's
No,
video.
it is not slide. It is
This is
my
video, ma.
my video.
Okay. Then it is okay.
This
Then it
Yeah.
It is this way only. Yes, sir.
You please interrupt me if you cannot see my video. Please
No problem.
interrupt
Okay.
me. Okay.
Yes, sir, we can see, sir.
Yeah. So before starting my video, I'll give you some brief that before a decade, the cesarean myomectomy was abandoned because of fear of obstetric hysterectomy, because of fear of massive hemorrhage. Then the time came that all these organizations like RCOG or AJOG or FIGO, they suggest that selective myomectomy, that in some cases you can go for cesarean myomectomy, not all cases. But with the advent of good anesthesia, with the advent of good suture material, with the advent of good surgical expertise, with the advent of availability of the blood, now all these organizations says that cesarean myomectomy can be done and it is safe with proper experience, with proper expertise. So now the cesarean myomectomy is no more abundant or no more a taboo. So because why to go for another laparotomy or another laparoscopy if we leave the myoma there during cesarean section? Now, if you discuss a little physiology of this myomectomy, that why cesarean myomectomy is more easier than the gynec myomectomy. Because in cesarean myomectomy, the advancing pregnancy that generally push the myoma towards the abdominal cavity, because there is an intrauterine pressure of the Leica amnii and the fetus. So all myoma that were supposed to be intramural, that becomes subserous. So in pregnancy, most of the fibroids, they become subserous because of the intrauterine pressure. That is a one advantage. Now, second advantage is because of the frequent Braxton Hicks contraction. There is a constant uterine contraction is going on. So you will get a better plane while dissection. That is the second thing. And third thing, that after the delivery of the placenta and the fetus, uterus become vigorously contracted. So in postpartum phase, the uterus generally become a very less vascular. So that is also advantageous for cesarean myomectomy. So these are the few physiological changes during pregnancy that will facilitate or which will indirectly help to go for a myomectomy. Now, when we started doing myomectomy, in initial 1 or 2 cases, we use a vasopressin, but immediately we got some cardiac arrhythmia. So now we are not doing installation of the vasopressin in cesarean myomectomy. That is the one thing. Second thing, in initial cases, few cases, we tied the uterine artery or we have ligated the uterine artery, and then we were proceeding for the cesarean myomectomy. But now we have stopped for installation of the vasopressin or doing the uterine artery ligation. Now we straight away go for the cesarean myomectomy. And the one more thing, that either you can close the uterus, that is hysterectomy incision, and then go for myomectomy, or if you feel that if you require a through and through suturing, then you can keep the hysterectomy incision open. That is up to you. So now we can keep the uterus open, or we can close the uterus and then we go for a cesarean myomectomy. So these are few points that will help or that will facilitate to go for the cesarean myomectomy. And as the Ashwath has rightly said, that Ashwath is also doing a very good high risk obstetric work. I also admire his work always. So cesarean myomectomy. So I'll show you the small 4 clips of different. One first, a simple myoma, which is easy, then a little difficult myoma. And here the success of myomectomy, it depends upon the 2 things. The one thing is if you remain in the proper plane, there won't be bleeding. That is one thing. And second thing, a closure. When you are closing the uterine wound or myoma bed, then you should remain careful, that I'll show you. So we'll go for a first case. This is a case number 1. Here, generally, I prefer to put a elliptical incision rather than a straight vertical incision, Because if you are putting a straight vertical incision, then at the upper end or at the lower end or at the both the end, there will be more oozing. If you are going for an elliptical incision, then at least on those places you need to go for a less dissection. Now it is always felt that at the top the dissection is always difficult, and as you go from away from the top, the dissection is always easy. So with the cautery, either coagulation current or a cutting current, we just cut the capsule, and then easily with the scissor like this we can do. Or now we are using, this is kind of a open shearer, that is open bipolar now. So open bipolar we can do this like this. So I had just for demo purpose I have shown this open shearer or open bipolar. So if you are using an open shearer bipolar, there won't be absolutely no bleeding like this. So for larger myoma, we are using an open bipolar or open shearer. Now the technique of the closure of the uterine bone is just go a parallel kind of suture parallel to the uterine bone. This was a initial surgery, so it is taken from the mobile and it was a little distance. In next video, I will show you. So this kind of a suture, it is a transverse suture. It is a parallel to the incision. So this same kind of suturing can be helpful in even episiotomy bleeding. It can be helpful in placenta previa or accreta uterine bleeding. You can go for that. And then second closure is just what we popularly call as a baseball technique or a football suturing. The second layer is kind of this. So I generally prefer to take a 2-layer only like this. And generally doesn't require any even mop also, or even blood transfusion is a very remote thing in cases of the simple myoma. We don't require a mop even also. The second case, this is a large myoma. So in this large myoma also the same thing. What we will go for a elliptical incision like this with a coagulation current, not a cutting current. So there won't be much bleeding. So as soon as we cut down or we incise the capsule of the myoma, so generally the myoma will start popping up from the bed. Then it is not that popular that if you incise the myoma capsule, there will be a hemorrhage or there will be a torrential bleeding. It is not like that. So if you are doing a proper dissection, there won't be much bleeding. So this is a little bigger myoma. So once you cut down the capsule of the myoma, then you can easily enter into the space, proper space. And I'm using a scissor here. I'm not using anything. Just with a scissor I can cut down. If I am in the proper plane, so there won't be any bleeding. That you can appreciate. So the big myoma with a scissor, with a sharp dissection, still there is no bleeding. So if you remain in the proper plane, so the bleeding is always from the two places. If you are in incorrect plane in the myometrium, there is a bleeding, or if you are in incorrect plane in the endometrium, there is a bleeding. So if you are in a proper plane, if you don't disturb the myometrium or you don't disturb the endometrium, there won't be much bleeding. So here we are in the proper avascular plane, like this. So here you can appreciate this is a big size myoma, almost 8 centimeter myoma, 9 centimeter myoma, and with this only scissor, without disturbing the endometrial cavity, we are cutting the myoma. Okay. Now you see how I do the suturing. And when you are putting a vertical incision or a transverse single incision, there is both the angles are bleeding much, because in some surgeons prefer to put a suture, then cut the myoma, then putting a suture, then cut the myoma. I am not doing that. Just you take a deep bite with a 1 number vicryl and take this kind of the parallel suture to the uterine incision. So this will all block the vessels which are going and which are supplying to the bed. So here I am not going for a single locking or unlocking continuous suture. I am not doing that. I am going for an interrupted that to parallel suture like this. So there won't be any bleeding much if you are doing a closer like this. And after taking our first layer, and you can appreciate that there is hardly any bleeding. So this is a secret of the closure. If you are going for a this continuous locking or continuous non-locking suture, there are all chances that you'll get a post-operative hematoma formation in the scar or post-operative bleeding from the scar. But if you are taking a suture like this, there is no chance of any hematoma formation or any bleeding from the uterine incision. So with the interrupted suture, we close the primary incision of the uterus like this. And then for proper approximation of the upper edge of the incised tissue, we go for a baseball kind of the continuous suture. So once you start doing the obstetric myomectomy or cesarean myomectomy, the things are not that difficult. So from case by case, you can learn many things. So after inspecting all around from the uterus, I am starting a second burial kind of the sutures. So it will bury the upper edge of the uterine wall. So it will not give much adhesions to the surrounding tissue. This is the end. At the same time, the edges of the cut edge will not bleed. So if we take this kind of the burial suture or a baseball kind of the suture, so it has a two advantage that the edge will not bleed. That is one thing. And second thing, edge will not be remain exposed to the surrounding tissue like this. So you can appreciate there is hardly any bleeding while going for such a big myoma. Now, again, this is a simple myoma on the anterior wall of the uterus. So basically what I have observed that all the myoma either in the anterior wall, in the posterior wall, I have less encountered a very big cervical fibroid. Probably because that large cervical fibroid or large ischemic fibroid may not allow the pregnancy to occur. So that's why most of the fibroids we are getting are the anterior wall or the posterior wall or the ischemic wall or the broad ligament fibroid or the pedunculated fibroid. So if you are in a proper plane, there is hardly any bleeding, and we cannot apply a myoma screw many times. So we put a long artery forceps and we pass a long artery forceps through and through to the myoma for the proper holding. And many times we twist the myoma like this myoma bed, and then we can put a clamp and cut it like this. So we can also do this. And there was a small baby myoma within that was another one fibroid or myoma that was removed with the cautery. Here also we can use a bipolar shearer. If you don't want to use a monopolar cautery, you can use a bipolar shearer also. Again, you see the suture, that is a parallel to the incision suture. If we place only one suture and that is parallel to the incise wall, there won't be much bleeding. So now lately, now we are removing most of the fibroid or most of the myoma during cesarean section with this technique. And just a last case I'll show you, that is a degenerated myoma. This is a degenerated myoma. It is almost it is degenerated, and from tissues are coming from the myoma. Again, the same thing with the artery. Even I can separate if I am in the proper plane. See, this is not a seizure. This is a artery only. It's not a seizure. And then with the final, we can cut it down with the cautery pencil. So those who are watching video, and my just aim and motto is they can start doing cesarean myomectomy without any fear. And those who are doing cesarean myomectomy, they can do with utmost confidence that cesarean myomectomy is no more contraindicated surgery or no more abandonment. So most of the myoma we can remove with this technique, and we can prevent a postpartum complication like postpartum degeneration of the fibroid, postpartum pain, postpartum pedunculation, postpartum even many times the myoma comes in the uterine cavity and may protrude from the cervical canal. Also, if it is a big myoma in the postpartum period. So we can prevent a second laparotomy or second laparoscopy also if we remove during the same sitting. So there is no need of the blood transfusion, because if now we can remove the placenta from the placenta aetata bed, or we can remove the much adherent placenta, then this fibroid can be easily removed without any problem. So these were the initial days we were doing a continuous locking suture, and now we have modified our suturing technique. So my friends, both the chairpersons, Dr. Ashwin and Dr. Mahendra, thank you for introducing me, and Dr. Archana and Dr. Sneha, thank you for allowing me to share my my view. And that's why I've not made any PPT for this, because it is a practical topic. PPTs are more helpful in theoretical topic rather than the practical topic. So thank you so much. Thank you all friends for watching this surgeries. Thank you very much.
Thank you very much, Dr. Mahesh Gupta, sir. I invite Dr. Ashwin Vachani, sir, for their comment on Dr. Mahesh Gupta, sir.
It's an excellent presentation, Gupta, sir.
Thank you.
It's videos are very much clear, and definitely the beginners or those who are having some fear that it cannot be done have the now little bit confidence. And as you all know that I am doing since last 15 years cesarean myomectomy, and we have the largest series at our medical college of more than 100 cases of cesarean myomectomy, and our initial work of 30 cases already published in international also. So as you have rightly said that cesarean myomectomy is no more contraindication. Only thing little bit confusion created is experienced person can do. There are no definition for experienced person. Everyone has to do your own experience.
That is a self-evaluation.
Yes.
Confidential person.
If you feel that you are not capable of doing, you should do it.
Yes, but I am fully agree with you that I have done the more than 100 cases of gynecologic myomectomy, now more than 100 cases of cesarean myomectomy. Cesarean myomectomy is more easier than gynecologic myomectomy. I am fully agree.
Exactly. Because
And you have
physiology is helping us.
Yes. Just fibroid ne पकड़ीने खेचो तो भी plane बनेली जैसे. That is the advantage of cesarean myomectomy. Pregnancy itself will lead to the space, be it breast contraction, uterine contractions. And one more extra advantage here in cesarean myomectomy, if we give the uterotonic agents, like we are already giving the oxytocin drip, that contract the uterus, automatically there will be the hemostasis. This facility is not there in gynecologic myomectomy. That's why.
That are the things which I have to emphasize and I have to highlight it.
Yes, you are right.
It is easy.
Yes, yes, it is easy, and this contraction of the uterus due to uterotonic agents will lead to the hemostasis. So that's why it's very easy. It is more safe, less bleeding even as compared to the gynec myomectomy. I am fully agree with your sentence, sir. It's an
Thank you.
excellent.
And,
Thank you.
and I always regret that I am not attached to any medical college or any department. I always regret for that. Otherwise, I would have done more thing.
You already have a department after you. We all love to see you, sir, operating. There is
But for private practitioners, you are
Post-op-
you're a department in yourself. I would like to say what Kazi means to say. We learn so much, sir, from you. I have got some best paper prize in SABMA for doing a cesarean myomectomy, cervical fibroid. I still remember calling up sir, and sir said, do the devascularization. It will go very smooth. So thank you, sir. We learned so much. And Ashwin, sir, you are also institute in yourself. So I think we had a great time seeing the surgeries. Over to you, Kazi.
And one more thing, Dr. Sneha and Dr. Ashna, thank you for allowing me for just video, not a proper kind of PPT, because I'm very lazy in
But sir, this video is more important rather than simple
Yes.
PPT.
In fact,
I'm a little lazy for that.
No, Mahesh bhai, it
in
made
fact,
the
we
surgery
always
very
say,
clear.
in fact, we always say that we are not postgraduates, starting from definitions. All of us are practicing obstetrician gynecologists. Whatever, you have acquired your skill and knowledge or experience, that you have to share with others. So in fact, we are very happy to, it was a visual treat watching your video, myself. Thank you so much for that.
It's really wonderful, and it's a pleasure to watch Dr. Mahesh Gupta sir's video, because he is the person who can make a contraindication into an indication. Before few years, we learned that cesarean myomectomy is contraindication, but now he and Dr. Ashwin Vachani sir, all the stalwarts have proved that it is the indicated surgery during cesarean, that we have to remove all the myomas. I just want to ask one question to Dr. Ashwin Vachani sir. Did you have any other different technique of suturing the myoma?
Yes, I have little bit different technique for closure. I am closing in layer wise, depending on whether it is subserous or intramural. If deep intramural, then even in 3 layers. I just take from deepest portions simple stitching, and intermittent simple stitches in cavity, and last layer, superficial layer, is by baseball, that sir has rightly already said, inside out, baseball suture. And one more thing I have changed nowadays, with bigger fibroid, I have started using the bath suture, as we are using in laparoscopy. Again, advantage is there is no need for tying. So within few minutes, 2 minutes, we can close the bigger cavity. So that is the one advantage. As such, it is no actively bleeding. So there is no worried about that you take the 2 minutes or 5 minutes. But advantage, if multiple fibroids, big fibroids are there, even we can use this barb suture also. So there are two advantages. One, time saving is definitely no need for tying. Another thing, it gives the approximation good. So there are less chances for the dead space. That may sometimes create the problem. For example, if there are cavities remaining inside, the bed is having some cavity, then it leads to the collections, and later on, I have required the one laparotomy for cesarean myomectomy in more than 100 cases of cesarean myomectomy. That reason is there is a collection in the myoma bed, and later on, after 10 days, patient develop the high-grade fever and abscess formation. So later on, I think that how we can prevent this. And now I have started using in deeper cavity the. So that will be the one advantage. There are no randomized control trial whether it is really advantageous or not. But theoretically speaking, definitely, if once you tight the barb suture, there is no slippage, and you can obliterate the cavity properly. Mahesh Gupta, sir, your opinion on this?
Yeah, see, I learned this closure technique by doing a vaginal bleeding control in postpartum period. I've attended 2 calls for vaginal bleeding after forceps delivery.
Okay.
And that gynecologist was taking a suture, simple continuous suture, but bleeding was not getting stopped. So I took a double end needle, and I pass one needle from upside and second needle from below, and then I tied. So with only two suture, I stopped all bleeding. So then I was keeping a round body needle with me when I used to attend a call from normal delivery bleeding. So when I pass a suture from a single needle from one side, and then I pour that round body needle on another side and then take. So that gives a best result. So then I started doing this technique. And in case of a cesarean section, in cases of placenta previa or placenta accreta, where the lower edge is very thin, and in those cases, if you are going for a continuous unlocking or locking suture, then against that, if you are doing this interrupted suture, it gives the best result. And as far as the placenta accreta suture, this interrupted like transverse, parallel to scar suture, there was a paper from the Japan that it gives a less chance of the future scar pregnancy. So basically, I learned this technique by doing a vaginal bleeding or vaginal hemostatic suture after a forceps. Then I'm doing now with all myoma like this.
Mahesh Gupta sir, so you are using your own needle while doing this myomectomy, or Vicryl 1 number on needle?
Vicryl 1 number, and I use a 50 mm side round body needle.
Okay.
So always use a round body needle. Don't use a taper cut or a cutting needle in a myoma bed suture. Always use a round body needle. So it
So parallel to the incision, that
Parallel
is
to the incision.
best
So
for
basically what
hemostasis.
happened, the blood, what you are cutting, the blood vessel
Right.
is going from that area to the bed.
Right.
Okay. So if you are cutting like this, then vessels are going like this. So if you suture this, the vessel will stop.
The same manner we are suturing.
Physiology. And if you are cutting like this and then you are going like this, the bleeding will not stop. Can you follow my point?
Yeah.
Exactly.
Yeah, cut like this, and then you are going a suture like this, then
Yes.
bleeding will stop in the center. And if I am going a suture like this, the bleeding will not stop, it will even continue. That is,
I think
that is a simple thing.
Dr. Ashwath wants to make some comment. Please, Ashwath.
Please.
Mahesh Gupta sir, it was an excellent presentation.
Thank you.
So as usual, so just a few comments, because as a referral center we are doing regularly. Just first comment is that last week we had a patient referred with secondary PPH. Okay, secondary PPH, first post-op, first cesarean day, first cesarean, first post-operative day, first post-operative day. The problem symbol it was there was a large myoma inside. And the surgeon who did not do myomectomy, did cesarean, did not do myomectomy. Torrential bleeding, patient was in shock. So emergency had to open it up and do the myomectomy. Okay, and save the patient. So the moral which I wanted to tell is that people still believe that, as you told, that one thing. Then I removed recently, 6 months back, I removed 30 myomas in a cesarean, along with cesarean. So, so one difference with when you do myomectomy is, both of you told, just I wanted to highlight is that here you cannot do in a one incision and tunnel and go and remove. Never do that. You have to put separate incisions, where if it is too close, you can extend the incision and take it. Many of the time you may have to put separate incisions for each myoma, like Mahesh Gupta sir was showing you. So that is very important, because, and Ashwin sir was telling very important point, that whenever it's a deep myoma, you have to put deep sutures. So whenever it's a submucous type of myoma, because when it goes too much submucous, as both of them told, most of them will be pushed up into the intramural or subserous. Sometimes it is too deep. Then what you have to take is that you have to take deep sutures separately. And Mahesh Gupta sir exactly showed that box sutures. That is, you have, so parallel, then you come like this and then take it. So it goes, so, and later, he takes the baseball sutures. And one more thing, many times myomas may be rarely at the site of lower segment. So you may have to remove the myoma, then go down and then take that. Because with the myoma, you don't try to put the incision over just above the myoma and try it, then you will not be able to deliver the baby. So And even to that extent, nothing wrong in an emergency of putting if it's a large lower segment myoma, putting a vertical incision. That's a classical incision over the upper segment. So much we are doing. That is why all, and the best comment from both of you all that it is easier than a normal myomectomy in a gynec. So that message is what is the most important message that you should go. So many techniques we had tried initially. We tie around, see, when times it's a multiple myomas, so we have to suture all this myoma. So in that case, what we do is that in the lower segment, just take a Foley's catheter and rotate around the lower segment, just tie it around the lower segment, including both uterine arteries. Then you do, so as both of them told, it is very vascular, using vasopressin. Carefully, it's okay, but too much vasopressin into the pregnant uterus, which is very vascular, be careful. With the anesthetist, be your concern with the anesthetist, then only push all these things inside. Excellent presentation, excellent take-home messages. I enjoyed it. So I was listening completely to all your videos as usual. Thank you.
Sure. Thank you so much. Thank you very much.
Thank you.
Thank you, Ms. Gupta sir, and both our chairpersons. Now I handed over the.
Thank you, Dr. Kazi. Thank you, Dr. Kazi. Thank you to Mahesh sir. Thank you, Ashwath sir, Ashwin sir, and Mahindra Soni sir, all the stalwarts together on this subject, which is a need of hour. And now I would hand over the baton to Dr. Kirtan Vyas to conduct the second session. Thank you, Dr. Kazi.
Yes, thank you very much, Archana madam, and my dear friend Dr. Kazi. And I must say, before we go ahead with the second session, which is an interesting panel discussion on antepartum hemorrhage, I would like to thank Mahesh Gupta sir for the wonderful presentation. And sir, it was real visual treat. And I must say, I would like to make a small comment among all your stalwarts that if we go by a dictionary meaning of savior, so the word savior is actually does that mean that savior is a person who actually saves another person or something from a difficulty or some danger. And I would like to specially mention here about Dr. Mahesh Gupta sir, that he has been a real savior to all the gynecologists in Ahmedabad, not only in Ahmedabad, but to even other parts of Gujarat. And he has been instrumental in saving so many maternal lives in cases of difficulty in PPH and so many other different and difficult obstetric hemorrhage cases. So we must thank Dr. Mahesh Gupta sir for all this. And we have been fortunate enough, some of our friends, that we have witnessed not only these video presentations, but we have observed sir operating live. So it's really a visual treat, and like the dissection by which manner he performs and the bloodless surgeries is a real treat to watch, sir. Thank you, sir. And this myomectomy was the presentation on myomectomy was also superb. And
for
so
those
apart,
words, actually, PPH
yes.
fan, and I think savior is another word for sir. We'll carry it forward.
Yes, yes, sir. So now we go ahead with the second session. That is an interesting panel discussion, and that would be carried forward by none other than Dr. Sneha Bhuya madam, the captain of the ship. And to introduce and to invite Dr. Sneha madam is a real privilege for me. And so many different awards and laurels to madam's credit. And most importantly, without going into the details of all these things, we all know her. Our best wishes from all of us go with madam. She is contesting for the post of Vice President of Foxy this year, and the elections will be held in August. So we compliment madam in advance for their victory. And we have also our expert, Dr. Vidya Thobi madam, with us for the panel discussion. She is a very senior name in Foxy. Right now, she is the professor and former head of Department of Gynecology at Al Amin Medical College in Karnataka. And she has been a president of Karnataka Society of Obs and Gynae last year, state advisory PCPNDT board of Karnataka. And she has so many contributions in Foxy as international and national faculty. So it is a privilege to have Dr. Vidya Thobi madam with us also. And we invite by this Neha madam, and we request her to just go ahead with the invitation to the panelists. We have so many different senior colleagues and friends as panelists to take part in this panel discussion from different corners of Gujarat. And we are sure that this panel discussion is going to be an interesting one with so many learning points at the end.
Yes, thank you so much, thank you so much, Kirtan, for that wonderful and generous introduction, I would say. With this, I thank all of you for joining this program. And of course, I would like to welcome my panelists for the panel discussions. I'm sure all of us are going to learn something new after our panel discussion. So I welcome Dr. Sujat Wali, who is the IVF specialist, philanthropy and humanitarian at Lara Mother Healthcare, Godra. So welcome, Dr. Sujat Wali, sir. Do we have Dr. Sujat Wali here?
Yeah.
I welcome Dr. Ashok Patel, who is the director of Mamta Gynae Hospital and Research Institute. He is trained in fetal medicine from London and also diploma in laparoscopy from France. So we're very happy to have you, Dr. Ashok Patel, and Dr. Palak Kapadia, the consultant Obs Gynae from Bharuch. So a young lady, we welcome you.
Thank you so much, ma'am.
Yes, so we have Dr. Falguni Chakkar, the gold medalist in Gynae Ops, and she is also serving in the Mother and Care Hospital, Bharuch. Of course, she's got an excellent academic career, and of course, so many gold medals in her PG and UG and PG curriculum. I would say she has delivered many public awareness talks as well, so that is good. Along with publications and the public awareness talks, I think very, very comprehensive work you are going ahead with. We welcome you, Dr. Falguni. And Dr. Rakhi Patel, yes, from Anand, the consultant obstetrician gynecologist from Anand. Welcome, Dr. Rakhi. We have Dr. Rumi Bhattacharjee from the Secretary of Baroda. No, she's from Anand, Gujarat. And she's got 20 years of experience in the clinical surgical teaching and research work as well. Lots of publications, and her special interest is of high risk obstetrics and of course the gynec surgery. And she's at present the professor and head of Department of Obstetrics and Gynecology, the Paramuswamy Medical College, Anand, Gujarat. So welcome, Dr. Rumi. And we have Dr. Pinky Kataria as the director of Radhaswamy Multi-Speciality Hospital and IVF Center. We welcome you, Dr. Pinky. We have Dr. Shilpi Raval, who is from Nadiad, the new Surabhi Hospital, and she also has got an excellent academic career. So we welcome you, Dr. Shilpi Raval.
Thank you, ma'am. Thank you.
Yes. Thank you so much. I welcome all of you for this panel discussion. And without much ado, we would like to go ahead with a very practical discussion. Just now, I have shared with you my view also that, all of us are consultant obstetrician and gynecologist. The disclaimer is that I'm not here to teach anything. I'm not here to, evaluate you or have your viva. We are here just to share our experiences and to know what is evidence-based, because all of us should go ahead with the evidence-based practice. So without, going into theoretical discussion, I would straightway go ahead with the case scenarios. I hope all of you can see my screen, and it is full screen.
Still not, make it full screen.
Yeah, I will do that. I think now it is full screen. Yeah. So Dr. Sujat Wali, sir, we start from you. We have this primary gravida with 5 months pregnancy. She came with, so I'm sorry, I'll just take this. So we have this primary gravida with 5 months pregnancy, and she comes to you with bleeding per vaginum in the morning at home, which was painless in nature, and it stopped spontaneously. On further inquiry, she revealed that she has had spotting even during early pregnancy.
Net goes. Yes.
Yeah, can you, yeah, I think you can see, is it still shared? My screen shared?
Yes.
Because of the power failure, I think there is a little disturbance here. So, she's normotensive, non-anemic. Her uterus is 20 week size, relaxed. Fetal parts are well palpated. Fetal heart is also well hurt. At present, there is no bleeding. So, sir, what is your provisional diagnosis? How will you come to the final diagnosis, and how will you manage this case?
Yes, ma'am. I would like to put diagnosis as a threatened abortion because weeks of gestation is less than 20 weeks.
Correct.
And secondly, as uterus is relaxed, digital examination, per-vaginal examination is not necessary, but 100% sonography I would like to do.
Yes.
And the first possibility is either low-lying placenta, number one. Second is cervical pathology, polyp or cervicitis.
Correct.
Third is infection, severe infection and endometritis. And fourth is, yes, a torch infection. So in this manner, I would like to investigate her, and then I would plan out the management.
Yeah. So your final diagnosis will be definitely on the basis of ultrasonography. Correct?
Yeah.
So suppose your ultrasonography is suggestive of low-lying placenta and the retroplacental sonolucent zone is well maintained. The anomaly scan is normal. How would you take this pregnancy ahead? How will you manage this?
Conservative, I would like to manage this patient conservatively with progesterone, injectable progesterone to calm down the uterus and to keep the uterus calm so that uterine contraction should not start and increase the bleeding more. Number one. Number two, if I find that on following examination, the uterus becomes irritable or uterine contraction starts, then I would like to give tocolytic agents also in the form of duadilan, 20 milligram in IV pint. And
I would like to interrupt you here that this patient, I am giving you the findings that it is relaxed.
I read it, but on following examination, if I find irritability or uterine contraction is there, then I would like to.
But for how long you want to give tocolysis? Because long-term tocolysis, because it's only 20 weeks, okay?
Yes,
so,
I would not prefer to prolong it, continuously giving tocolytic for more than 48 hours. In between, I would like to add antibiotic also because if total CBC count is more, then I would like to treat the infection also.
Okay. So all other investigations are normal, but she has low-lying placenta on ultrasonography. Would you like to go for prophylactic osteotomy for this patient?
Yes, if there is no other cause and if she continues to bleed, then yes, I would like to offer them this option. But I cannot guarantee that osteotomy will definitely be able to stop the bleeding.
Any other opinion from the panel? I would like to have all of your opinion, all the panelists. Placenta line, what is your opinion about the cervical circulage?
Apart from
all of your
I'm not a panelist, but I want to add something.
Yes, I think we will. Okay, you can go ahead. But we have so many panelists, Dr. Kazi. We would like to have their opinion first, then we come to the conclusion. We will have your expert comments also. Okay. So I can see so many panelists here. I've already.
Circulage will be not too much helpful in this patient, and also tocolysis.
Yes. So we talk about cervical circulage first. Dr. Shilpi, yes, you can take this. I will not say your name. Please come forward spontaneously.
Yes, ma'am.
Yeah, please say.
I am not in favor of tightening with availability of good progesterone nowadays. We can control the contractions and we can keep the uterus calm. I am not in favor of tightening.
Okay. Anybody else? You want to add
Yes,
something?
yes. Hello. Yes.
I want to have all of your opinion. Please come on fast. We can go ahead.
Myself, Dr. Pinky Katare, I would also not like to go for the prophylactic or tightening.
Okay.
Whether it is the almost the second trimester and the low-lying placenta, with the progress of the pregnancy, placenta may upgrade on the next
Migrate. Okay. Anybody else wants to add? I would
Yes,
request
no,
all of
even-
you to rename yourself so that I can, call you. Dr. Ashok Patel, can you please?
Simultaneously, internal source is open and cervix is short.
No, we
and
don't
then
have.
it will
We
be-
don't have. We don't have. The cervix
So-
is absolutely
so it
fine.
is not helpful in the.
Yeah.
So it is not helpful in the placenta previa.
Yes. Yes. The
Also
next.
prophylaxis, madam. Only progesterone will help and bed rest.
Yes. So the consensus here is there is absolutely no role for prophylactic or tightening. I know that all of you will say that I give in my practice, but what the evidence says basically for a low-lying placenta, where actually you are trying to avoid the internal examination, you are trying to avoid even the intercourse. Why should we interfere and go for the stitch? That is the first point. Secondly, what does the evidence says? That the evidence says that only when you have short cervix, that is when the cervical length is less than 2.5 centimeter, that is 25 millimeter. So Foxy, ICOG and even FIGO, it recommend that you have to go for cervical cerclage only when the cervix is short. Okay. Foxy has got, FIGO has gone ahead and endorsed that even when you have a short cervix, cervical cerclage and vaginal progesterone, they are equally safe and effective. So even it can be, the vaginal progesterone can be even the alternative for cervical cerclage. So that is how. So absolute no for the cervical cerclage. Now, what is the role of tocolysis? Dr. Sujat Wali has already said that if at all she has contractions, but our patient doesn't have contractions. Okay. So basically, when do you want to give tocolysis and for how long? Not for this patient. For this patient, it is absolutely no. My question to the next panelist is, when do you want to give tocolysis? What is the rationale and how long you can give the tocolysis?
If it is needed, then up to 34 weeks.
No. Long-term tocolysis is nowadays strictly prohibited, I would say. Okay. So previously we used to give whatever we used to use, isoxaprine, etc. But nowadays the consensus is that you can give tocolysis only for 48 to 72 hours, and that the rationale is only till you reach the patient safely with in utero transfer, or till you
Control the steroid therapy.
steroids act. Okay. So that's the only indication. So near about 32 to 34 weeks, if you want to continue this pregnancy, want your steroids, want a time for magnesium sulfate, then only you should go for tocolysis. Now, what precautions to be advised? I have already said few, but I would like to have your words from this, all of your comments. Yeah. And if you can rename yourself, please, it will be easy for me. Yeah.
This patient is already bleeding from the first trimester, slightly. That is a more chance of the further bleeding in the further pregnancy progresses. So I would like to build up her hemoglobin every time, giving some extra iron and the higher protein side and some of the minerals. It's very important for this. Whenever the patient is having the acute blood loss or hemorrhage, so she can sustain her hemoglobin and vitals on that time, and good vitality of the mothers can be sustained. That is first. Rest is also needed. As far as you said, is the intercourse is not needed. We have to see for the cervical infection or the vaginal infection whether because she's repeatedly bleeding. That might be some of the infection. We should go for the culture also that, and according to the bacteria or the we have to treat an infection also.
Yes, so she has to avoid internal. Yes, Doctor.
I would like to rule out
Yes.
coagulopathy.
Yes,
in the
that is
form of
what.
hemophilia, factor 5 laden factor, and
Yes.
prothrombin also. As
So-
well as I would like to rule out torch.
Yes. So you can see in
Also,
this list
because
of
she is
investigation.
repeatedly bleeding. She is repeatedly bleeding.
Okay. So this, you can see the list of investigation. Don't take anything for granted. even if you're quite sure that the placenta is low-lying. But sometimes when you have the separation of the placenta, even minimal, you may have the coagulation cascade, activated. And that's a very reason, even with little bleeding, you can go ahead with the coagulation profile. Now, in addition, Dr. Kazi, do you want to make some comment here? Okay, so what are the RCOG green top guidelines as far as this low-lying placenta is concerned?
Grade 1.
Dr. Ashok Patel, we can have your comments on this.
So it's a grade 1 placenta. It should be grading grade 1, 2, 3, and 4.
When should we do the ultrasonography? How should we label the placenta as low-lying?
It should be only after 18 to 20 weeks rather.
Right. So at around 16 weeks, when you do the ultrasound, you can have a suspicion. Okay. Okay. Just let me know when should we do label her as having a placenta previa.
At the time of anomaly scan rather.
Yeah. So when the placenta covers the entire internal os completely.
Yeah.
Right. So that is how. So we have discussed about the tocolysis and the cerclage, everything. So now what is your aim of this pregnancy is to continue the pregnancy ahead. So with everything, as you have already said, that you will, investigate her, confirm the diagnosis, you will give her all the precautions and take this pregnancy ahead. Now, how do you want to go ahead with the further management? Dr. Shilpi, Dr. Pinky, Dr. Palak, and Dr. Falgun. Please come forward. We would like to listen to you.
So after doing all the investigations, ma'am, we can tell her about all the precautions that she needs to take that we've already mentioned. For example, no intercourse, no travel, no lifting of weight, etc. And with our regular antenatal follow-ups, maybe we can do an ultrasound.
You want to hospitalize her, or you want to manage her on domiciliary basis, domestic basis?
See, since the bleeding has stopped, she can go home, but with adequate bed rest.
Okay.
And no strenuous activities.
Okay. What about blood and whether you want to reserve blood for her?
Close to, okay.
Yes. Please go ahead. Please go ahead. You can see all of you.
We have to reserve her blood for any emergency occurs if it is a stamping out of the placenta previa and it is bleeding every episode, and if sometimes it is a very large amount of the blood loss, she may require multiple blood transfusions. So we have to carry a message to the relatives or the consent of the relatives to be taken from the. They have to manage the multiple blood transfusions, so they can be ready before the delivery. I generally take in the Gujarati that this is a bomb case because of the placenta previa. It can kabhi bhi fat sakta hai. So that will be even she is coming by her walking, but the bleeding can start and she might collapse anytime because of the bleeding. And relatives always counsel about the reserving of the blood.
So counseling has a very, very important role here. You have to tell them that irrespective of all this, management, taking every care from your side, arranging blood, and we are also trying, but this is, the dormant bomb. It can explode anytime. And of course, you have to be ready for whatever emergency it happens. Nobody can prevent this because it's a placenta previa. There's no way to stop, that it from bleeding. So that is so. So how long do you want to continue this pregnancy, Dr. Shilpi, Dr. Pinky? I would ask, do I see Dr. Palak? Dr. Palak?
Yes, ma'am.
Please go ahead. How long do you want to take this pregnancy ahead? And when do you want to plan a delivery? How do you want to plan it?
Yes, ma'am. At 36 weeks, we would like to do an ultrasound to see where the placental location is.
Okay.
If it has migrated, then she can carry on till 40 weeks or she goes in labor.
Do you want to wait till 36 weeks or even at 32 weeks you need to
Yes,
see?
ma'am.
Yes.
I
Because
thought we've
if at all
already.
it has to migrate, it will be during the second to third trimester itself. Otherwise, once after 28 weeks, I don't think there's any scope. Okay, but is it really a migration, or it is just, the expansion of the uterus, the growth of the uterus? Yes, Dr. Palak?
Yes, it is the growth, ma'am, but we generally term it as migration.
Yes. So you will do her ultrasonography at 32 weeks. Again, you confirm that it is low lying. As long as there is no bleeding, you will try to conserve this pregnancy and take it forward. Meanwhile, as we have already talked about, what do you want to give for the baby, because you're not sure what time
Steroids.
is going to bleed. Yeah.
Yes. We
So
should
what
give
steroids you want to
Steroids.
give, how much, and what magnesium sulfate, how much?
at 32 weeks. I would like to give her antenatal steroids. I'm not sure about
The
magnesium
magnesium
sulfate.
sulfate should, if the patient is preterm, extreme preterm, magnesium sulfate has a role up to the 32 weeks. After that, the baby neurons has been very well developed. So we can avoid the magnesium sulfate after 32 weeks. But if it is a early hemorrhage and we have to take the decision earlier in preterm delivery, then magnesium sulfate I would like to give. Antenatal steroids can be given up to the 34 to 36 weeks, because the lungs protection, it is very necessary.
Which
for the
steroid do you use and how much?
Dextrosol, 12 milligram, 2 doses, 12 hours apart.
Okay.
And if pregnancy continues for longer than 7 days, then we can repeat the dose after 7 days.
I would like to disagree with it. It is usually said that repetition is not required for betnazole.
It is correct that once you give that particular, complete schedule of 24 hours, there is no need to repeat. In fact, there is no role of even the rescue dose of steroids. Okay. So it is not that. In fact, it has been quoted and as evidence in IFP that they have said that even repeating the steroids does more harm to the baby. What is called cerebromalacia.
It can cause cardiomyopathies in
And
the baby.
autism, right. So definitely you are not supposed to repeat the dose. Whatever you want to give as a prophylaxis, that's a single dose schedule. That is 24 hours, 24 milligram over 24 hours. How much magnesium sulfate you want to give? How do you give magnesium sulfate?
As a Pritchard. Same as a Pritchard regime we are giving to the
24 hours.
Is it?
eclampsia for the 24 hours.
Okay. So you are using Pritchard's Maxwell regime. Any difference of opinion here? What most of the, all over India, what it is followed, or maybe what the guidelines are saying, it is the intravenous regime which is followed for neuroprotection. And because of the advantages of administration, and of course you don't face the painful injections, and every 4 hourly you have to give, you have that 100 ml IV mag nowadays available. That has made it very easy. Previously also it was easy, like you give 4 gram of loading dose intravenously for the first dose, and then you continue the IV infusion. So 1 gram per hour. So if you have a pint of 500 ml, you just add 5 ampules to that, give 100 ml per hour. For some of the patients where you don't want this additional fluid, maybe you need fluid restriction, and that is why the pharma has come up with 100 ml IV mag solution. So we have been using it very regularly. Like you give initial 100 ml of the pint as loading dose, and then you continue as up to 24 hours. So 100 ml solution or pint, that small pint has 4 gram. Okay, so 1 gram per hour, that means 25 ml per hour. That is how it should go. And you have to give it for 24 hours. Here again, if the patient doesn't deliver within 24 hours, or you don't have to take her up for cesarean section for 24 hours, within 24 hours, you don't have to repeat it. This is again a single dose schedule. So for this is what all of you know how the placenta is graded according to the the location. So now what precautions you want to take for before cesarean section? What all things you want to be ready, and what complications are likely to be faced during this procedure? Dr. Falguni?
Yes, ma'am. So placenta previa, we expect a lot of PPH. So before we take her to the OT, we have to explain her very nicely that in case we are not able to control the BP, the bleeding, we may have to go for stepwise devascularization. We may have to go for BLH, or we may have to go for subtotal hysterectomy if we are not able to control the bleeding. The second thing which we have to tell them is that they have to be ready for massive blood transfusions. So we have to have the donors, and we have to check it at the blood bank whether the PCV and the platelets concentrate and the FFP is available or not.
Correct.
Whenever we go for
Precautions
cesarean,
do you take before, sir? What is the consent you have? You have already said that we will discuss with the relatives, but you have to take an informed, written consent of everything, right?
Yes,
Up to hysterectomy, and
Yes.
even the patient can become moribund. Okay. Is
Yeah.
how. Okay.
So
What the precautions you want to take before the surgery, and what incision you want to take for this cesarean section?
So, ma'am, usually we go for a fenestrel incision only.
But it has to be little liberal.
A liberal fenestrel incision. Yes.
Okay.
And then we go for a liberal fenestrel incision, and then we deliver the baby by a lower segments incision, and then if there
where should we place the incision? That is what the question.
A little above the placental site, if you can make it out. Otherwise, you can put it on the lower segment also. You can, if it's the anterior placenta, you can cut through the placenta also, deliver out the baby, and then deliver out the placenta. That's also perfectly fine.
Okay. Okay. So
I would have I would have my additional comments that this patient is going to be that during the surgical procedure is going to have a larger amount of the blood. So I would infuse the more than 1.5 liter of the fluids or some crystalloids if it available, and then I'll take her to the on the operation theater. I would advise the anesthetist to keep everything ready before that, and of course, before in the labor room, I would go for another sonography for the location of the placenta, whether it is adherent or not. That is a pass which is very much famous now in every emergency gynec procedure. So that would be deciding my incision on the uterus.
Yes. So
if it is a pass, then my incision would be higher.
Yes, whether you would like to prefer the incision where you can go in between the placenta and the fetal head, or you want to cut through the placenta, and how do you decide that? Because we have already said you have to map the placenta site, and you have to take the incision little higher above this, right? That will be preferred. So if you cut the placenta, you lose lots of blood, and that is usually a fetal blood. Okay, so that is the reason you are supposed to try and avoid cutting through the placenta. Right. What precautions do you want to take after you deliver the baby? Suppose once the placenta is low lying, that is bleeding. So once you remove the placenta, is that all? Now should her bleeding stop, or any other precaution you want to take for this patient?
There are chances that she'll keep bleeding from the lower segment, because the lower segment does not involute or contract as nicely as the upper segment. So we do a watchful observation whether it's still bleeding or not. If it's not bleeding, well and good. If it continues bleeding, then we may have to take steps to control the bleeding.
Right. But do you want to wait for her to bleed, or you take some prophylactic measures?
See, ma'am, prophylactic measures normally
because the placenta is on the lower uterine segment, which is actually a passive segment of the uterus, right? On top of that, you have large sinuses there. Okay.
So we can take stitches on the lower segment, or you can go for uterine artery ligation, or
Any
you can go
question about the oxytocin, what I mean to say now, all of us have stopped.
Prostaglandin,
Yes, very right.
tranexamic acid.
Yes. So first and foremost, you will give her 1 gram of tranexamic acid just when you are taking her for cesarean section. That is the first thing. Okay. Secondly, you may have to modify your oxytocin, as Dr. Sujat has already said that, ergometrin is the only oxytocin which acts on the lower uterine segment. Oxytocin and carbetocin do not act preferably on the lower segment. Okay. So ergometrin is the drug of choice for this kind of patient, because, once the uterus contract, that vessels automatically get occluded. So you may not have to use anything else. What sinuses, you may not have to go for the stitches also. So you're right, actually, that initially you should see to it that you give some effective oxytocics. And if at all it is bleeding, what is the role of packing, Dr. Sujat and Dr. Ashok Patel, sir? I would ask both of you.
First, after delivering the baby, I will not remove the placenta. I make a hole on by both broad ligament and do the tourniquet with Polish catheter or any something thick gauze piece.
Okay.
Then I will ligate both uterine arteries.
Okay.
Then deliver the placenta.
Is it mandatory for all the cases, or you feel that only in some cases? What is your?
No, it's in major degree placenta previa and center placenta previa is mandatory.
Right.
If it is
Okay.
grade 1 or 2 placenta previa, then it is not mandatory.
Yes.
But for prophylaxis, it is ideal to
Stepwise devascularization. Yes.
stepwise devascularization.
Okay. What else? What is the role of the pressure? A balloon tamponade?
Pressure
Maybe
in practice, I have not found it is effective.
Packing will be not effective in the lower segment rather.
But
it
is not very effective.
After delivering the placenta, it will be easier to take the cervico-ischemic suture.
Right. Perfect.
Putting the dilator inside the cervix, and you can take both side 2 or 3 stitches cervico-ischemic suture. Then almost, I think, all the placenta previa bleeding will be stopped in uterine artery ligation and cervico-ischemic suture.
Correct.
Inserting balloon will not provide the surety of the hemostasis, complete hemostasis.
Correct.
So sometimes we get false impression that hemorrhage is stopped, but it may continue inside behind the balloon also. So it is not preferred to depend on balloon.
That you seek hemostasis then and then only. Don't give anything.
You can take anterior and posterior all separate hemostatic stitches, even after this cervico-ischemic suture and bilateral uterine.
The hemostatic figure of 8 stitches for the lower uterine segment where the sinus is subleading. Perfect. So very well discussed case. Now we go ahead with the second case. We will just have very practical discussion. We have the second gravida, para 1, which comes to you with 9 months amenorrhea and now labor pains. She's got her vitals are otherwise stable. Pulse rate is only 100, and uterus is full term contractions are good. 40 seconds every 3 minutes. The counter is well maintained. The head is fixed. Fetal heart is 140 per minute. The patient started bearing down, and there is spontaneous rupture of membranes with fresh gush of bleeding. Okay, so there's sudden drop in fetal heart rate. What do you feel is the diagnosis for this patient? The bleeding is not very severe. It is, but there is a fresh gush of bleeding. Dr. Ashok Patel, this is a case for you to discuss.
Since it's a registered patient, madam, I assume placenta previa is not there. So with the sudden rupture of membranes,
the head is also fixed.
So bleeding came. So I would like to put a diagnosis of accidental hemorrhage. Because it's a drop in the fetal heart.
Any differential diagnosis, and how do you confirm it? Yes.
With the sonography. With the sonography.
Now we don't have time. She's already in fetal distress.
So it's a fresh gush of bleeding with spontaneous rupture membrane. I will directly put the diagnosis like an accidental hemorrhage, and I will put label the code red.
Ma'am, can I?
First, I will label this code red. I will put the all code in my labor room. I will buzzer the code red. So everybody will be alerts. So first IV line, cross match, oxygen.
Yes, but Dr. Ashok Patel, let me clarify here. The patient is not bleeding profusely.
Okay, ma'am.
The patient is not bleeding profusely. She was vitally stable previously, and she is vitally stable. Only fetal distress. I'm giving you. Yes, Dr. Falguni.
Yes, ma'am. So the only thing which I am getting out of this is that there was rupture of membranes, there was a little bit of bleeding with sudden drop of FHS, which is not inconsistent with the amount of bleeding. So
Yes.
this points towards vasa previa. There
Perfect.
must be, there must be the marginal attachment of the cord which was passing over it, and with the rupture of the membranes, those blood vessels have ruptured. So the management of this is immediate delivery of the baby by cesarean section.
Definitely.
Vasa previa
Definitely.
is the indication. Yeah.
In the case of vasa previa and fetal bradycardia will occur definitely. It will confirm the diagnosis.
Yes.
Then if we have facility to differentiate whether it is fetal blood or
That is
maternal blood,
later on.
then
Clear acid
we can confirm the
elucidation.
diagnosis.
But
Okay.
if it is
So as
if
soon
it is
as possible, delivery.
First and foremost, you have to deliver the baby by whatever modality early.
full dilatation is there, patient is actively bearing down, that might be a rupture of the membrane after, full dilatation. So we can deliver vaginally also if you have other modalities like Ventus or if it is in favorable vaginal delivery. If it is not favorable founding, then we have to go for the immediate cesarean section.
Yes. So the word of caution here is, even if she is fully dilated, fully phased, she is bearing down, but maybe whatever inevitable time she takes it for second phase of second stage of labor, you have to keep everything ready for cesarean section and you deliver in OT. Maybe it may be an instrumental delivery when you have the anesthetist, neonatologist, everybody ready, because vasa previa is such a condition that even when you manage so aggressively, almost 60% of the fetal or neonatal mortality and morbidity.
Same like cord prolapse rather.
Yes.
Both
So
are same.
that is the very reason, even with minimal bleeding, you are getting fetal distress. So your only way of, thinking forward is to deliver the baby at the earliest. Then you look for whatever may be the cause. So this was the cause. You can see the cord getting divided into two, the entire amniotic sac. And here on this side, you can see the rupture also. Then, of course, when you perform the clear bed acid dilution test, you may find that it is fetal blood, but this is a sample which is retrieved of that patient. Okay. So, short case, very interesting, but it tells you, makes your antenna sensitive that yes, this also can be a presentation. And when you have no low-lying placenta, not hypertensive, here Dr. Ashok Patel has said, abruptio, you can see here, abruptio placenta and rupture uterus. Because when she's bearing down, she gets a bleeding, So rupture of uterus also should be one of the differential diagnosis. But because all these are other factors which are favoring vasa previa, and of course the management we have discussed. So this is again a lesson for all of us. Yes, Dr. Falguni, you want to
If
comment?
there's rupture, there should be a lot of tachycardia and a lot of hypotension also.
I think we have one more case here, which is silent rupture. And all of you know that, rupture can happen very silently. The patient may even continue to have good contractions also, right? So it is not a very clear-cut scenario when you have that, every time rupture uterus will be, very catastrophic. So not so, right? Agree? So we have this third case now, Dr. Palak, for you. We have 32-year-old para 1 previous cesarean section woman has only one child, male child, 1 year. And the first visit, she comes to you or comes to the doctor during her 6th month as a first antenatal care visit because of the job transfer of her husband. So when on further inquiry, she gives you a history of early pregnancy spotting, also where her old USG report suggests of low-lying placenta. Now, when you do her ultrasound, you find that yes, 26 weeks pregnancy, no anomalies, placenta previa with absent RP leg, right? So at 30 weeks, again, she starts bleeding at home significantly by the time she reaches the hospital. So it has already stopped. So you feel that, you should get her investigated and keep prepared. So you send her for investigation and she collapses. She starts bleeding profusely and she collapses in your hospital, Dr. Palak. How do you manage this patient?
Ma'am, first I would like to put a whiteboard needle and start massive blood. Sorry, ma'am. 2, yes. and start massive blood transfusion after adequate cross match and getting adequate blood.
Yeah.
Also, I would like to take her to
Start
the
the IV fluids because we will not have
Yes.
blood immediately.
Yes.
Start IV fluids from one side and send the lab on the other side.
Yes,
And the
ma'am.
moment you receive the blood and blood components, start with it. Okay.
Yes.
Go ahead.
And then I would like to check the status of the fetal heart rate. Also, we would like to start
What difference is it going to make in your management? Your patient is bleeding and she's collapsed. Okay.
We'll also start tranexamic acid,
Okay.
blood, and since she has history of placenta previa, along with probable placental accreta spectrum, we might have to take her immediately to the OT with keeping everything else ready.
I would interrupt you here, Dr. Palak. Whether it is accreta or no, your patient has placenta previa and she is bleeding profusely, you have to take her for and the procedure, operative procedure. Okay?
Correct, ma'am.
Yes. So what kind of operative procedure you are planning, that will depend whether it is accreta. So it is accreta. Now you tell us, what will you have to manage the patient, but you have to talk to the relatives also, correct?
Yes, ma'am. But also, ma'am, it also says that the bleeding had stopped by the time the patient reached the hospital.
But I think you are missing the next comment that she collapsed while she is gone for the investigation. She is collapsed in the hospital. That is why we are discussing this. She started bleeding again during the investigation and she is collapsed. Okay.
Yes, ma'am. So,
do we have Dr. Rakhi, Dr. Rumi?
Yes, ma'am. Can we take it forward?
Yes, please go ahead with the discussion. You are managing this patient because you are putting in 2 IV lines because she's bleeding. She's collapsed, my dear.
Okay, ma'am. So I would like to say, first of all, we talk about the diagnosis. She had history of early pregnancy spotting and there was a low-lying placenta. And she also has a history of cesarean section. And in the 26-week scan, again, it was confirmed placenta.
No, we are not going to retrospect. We are managing this patient who is bleeding profusely and who is collapsed.
Okay, so
Go ahead now.
I'll tell her relatives that it's a placenta accreta syndrome and she has to be delivered immediately. Now, for delivery, what we are going to do is that we have to tell her.
Is it that we have to say that it is placenta previa accreta, so we have to deliver?
So we may have to go for a hysterectomy.
Madam, again, I would like to do emergency sonography in the OT, which I keep always ready. And this might be a retroplacental clot or might be a rupture of the uterus and hematoma, which because of that she might have collapsed, or there might be some of the possibility of another bleeding which is inside. We can diagnose with the sonography that might be a lots of collection of the blood inside.
Dr. Sujatwali, do you want to make some comment here?
Yeah.
Because I think we're
There are
diverting
three
from our
other
case.
possible: placenta accreta, another is rupture of uterus, and third thing is accidental hemorrhage also, by chance. So all the things we have to keep in mind and we have to counsel first.
Yes,
We cannot guarantee survival of the fetus, number one. And probably we might have to proceed for hysterectomy.
Also.
And we might have to give lots of massive
blood transfusion.
All these things from the beginning.
We have to explain.
Yes. We have to call surgeon also, because if there is a case of accreta, then neurosurgeon will might be we may need
that will be the
help
next
of him.
question. Now I think we have come again back to the track that basically this patient has got placenta previa accreta, but he is bleeding profusely, may whatever be the reason. So you are not going to investigate what has led to this bleeding. You have to manage this patient, stabilize her, prepare your OT, arrange blood products, everything, and then you have to, you should have your different teams to talk to, but you have to talk to the relatives personally, saying that, if we don't, make some delay in taking her for operative procedure, we may lose her. So that is the reason we have to take her. Maybe the baby is only 30 weeks. We don't assure you that we can save the baby, but we have to save the mother first. And for maternal interest, we have to go ahead for the surgery.
Exactly.
Okay, so now that you have started deciding for the procedure immediately, things are ready. Dr. Ashok Patel, sir, I would ask you, whom all do you want in your team to operate? Dr. Ashok Patel, sir.
Yes, ma'am. So prepare patient for the emergency laparotomy.
Yes.
Yes.
Who all should be the part of your team? Who all?
All experts.
We will have to discuss with the anesthesiologist as well as hematologist as well as
another expert
neonatologist.
gynecologist first. Team of two gynecology.
Okay.
Then two anesthetic, one pediatrician, and if needed, then surgeon.
Okay. If you have the facilities, whom else you would like to call, whether a neurosurgeon or oncosurgeon? Any role for interventional radiologist you have?
Interventional radiology is basically in very few places they are active, even in the I think metro city like Ahmedabad or Surat or Rajkot or Bombay. So and with this, I mean that interventional radiology with uterine artery embolization, it is very difficult process and time consuming for the radiologist. Also, we have to shift the patient. That is not possible in this case of patient because she suddenly collapsed. So we have to maintain her vitals, maintain her urine output, maintain her everything for survival of the mother. So I would definitely go for the surgical procedure, laparotomy,
Emergency operative procedure.
operative procedure.
Okay. Now you tell me what precautions you have to take before, before the surgery. What incision you want to take? How do you deliver the baby? What do you do with the placenta?
Okay, a liberal incision should be
upper vertical. This is upper fundal to incision is ideal for
abdominal
this.
incision. Abdominal incision.
Abdominal also I would prefer the vertical. Also we might need some extra devascularization of the vessel that will help in the surviving of the mother. People are doing with the financial incision also internal iliac ligation but we may have to sometimes suppress the aorta to survive. I mean maintain the blood pressure, which is very good anesthetic job. But we have faced like heavy bleeding and aorta pressure is very much
yes, almost
I mean,
85%
blood pressure maintaining.
Right,
so I would definitely prefer for the vertical incision. Vertical incision on uterus also upper side, so we can easily deliver the fetus. Sometimes we have a very much accretable, I mean very much adherent placenta which cannot be removed. Otherwise, if we try to remove it, it will also bladder might be involved. So we have
so
to
that
take
is a question. Should we try to remove? If you are very
no, not at all. Not at all. If it is confirmed pakka case of the accreta, I would not go for the placenta. We just tie the silk or the something with the placenta in bed and we close the uterus. If the facilities for the further surgery is not available in our hospital, it is in emergency. We can't manage all the team which is very much active for this kind of patient. So we can, if the vitals are stable now, we can shift to the higher center with the all IV fluids and massive blood transfusion running on the transfer. Or if we have team managed, we can go for.
That is when the patient is not bleeding. Our patient is
not bleeding.
Yes. And she's collapsed. Okay. So here for this patient, we don't have that choice, right? So definitely it will be other way around. That if suppose this is for the elective cases when you don't have the facility, but here there is no alternative. You have to manage this patient. So call the expert obstetrician and a surgeon and go ahead with the procedure. So you have to take a classical incision, as you have very rightly said, or maybe what is called as a transfundal incision. Right? And you deliver the baby from the fundus itself, but do not touch the placenta if it is not separating. Now, here I would like to say, previously we had that concept of, it should be elective obstetric hysterectomy. Even today we have it because our majority of centers are not well equipped with the further operative procedure. But definitely if everything is fine and the relatives agree to it, that then we can go ahead with the obstetric hysterectomy. But if the lady is very young and if she is a primary gravida and they're not willing absolutely, then of course, Dr. Mahesh Gupta, all of you have heard today for cesarean myomectomy, but he has presented so many talks even for my other programs that, taking that Comox MG stitch and doing, the removal of the placenta, excision of the placenta. In addition to this obstetric hysterectomy, you have few uterine conservative surgeries, and that you can do in cases of patchy adherence. So one of them is triple P procedure. Okay, can anybody say what is triple P procedure? Triple P. Triple P is mapping of the placenta, that is placental mapping. Then you have pelvic devascularization, that is stepwise devascularization. Then you have patchy resection of the myometrium. So this is for the patchy adherence. But what Dr. Mahesh Gupta is discussing nowadays, and why we are saying that we are also changing the trends, that if you take that cervicoischemic stitch, on both the sides, you occlude both the branches of uterine. And of course, then when the patient is almost bloodless, the uterine field, you can scratch the placenta, the placental tissue, you can scratch and then you can secure it, hemostasis can be achieved. That is what he has been presenting, and it is quite a welcoming step. And, you have been listening to it that, even US and all these European countries, the patent is been received and people are following it. So maybe over few years, even all of us are, dare enough and experienced enough to tackle with such situation and go ahead with the uterine conservative surgery. Till then, we will just say that if possible, try to take a consent for informed written consent for the planned obstetric hysterectomy. It should not be a emergency. Otherwise, if you have not counseled the relatives properly, they will feel that you have done some mistake, and that is why now you are going for hysterectomy. So it has to be counseled before starting the procedure, because this is a problem. We may have to go for the planned hysterectomy. Okay, the planned hysterectomy, that means along with the seizure, we have already planned that to go for hysterectomy. So all the blood products, everything we have discussed. Now,
I would like to suggest two things, most important, practical. The
Yes.
anesthesiologist should be instructed or advised to keep ventilator ready, number one, and always it should be done with intubation.
Yes.
For better management of blood pressure, if hypertension occurs, then this is most important. Secondly,
CVP line has to be.
priorly, ureters should be stented.
Yeah.
On
If there is a
bilateral,
perforated
stenting
heart,
of the
definitely.
ureter should be done. In case we have to cut bladder partially, so ureter should not be injured. There is a basic two things are needed for every emergency, this type of surgery.
Some of the surgeons or even obstetricians, they are feeling that when you have placenta percreta, that means you cannot absolutely separate the bladder from the myometrium. You may, deliberately go for cystotomy, and because then it becomes very easy for the dissection. Okay, then you can easily repair the bladder rent, whatever you have made. That is what has been, discussed every time. So this is what is, once again, I don't think we should go for this theoretical discussion that what are the risk factors, but I would just ask you, what is the role of MRI for placenta accreta spectrum diagnosis?
Placenta accreta spectrum is very
compare
nice.
USG with MRI. Consider
Yes, there is no added advantage of MRI because USG very nicely detects the placenta accreta syndrome, both the sensitivity and the specificity of the diagnosis of PAS with USG is much higher. So actually there is no role of MRI. The only place it comes into picture is that when you are having a posterior placenta previa and you're suspecting that there is you're suspecting PS, only then you may think about doing MRI. Otherwise, there is no specific role of MRI.
And a morbidly obese woman where the penetration is
Yes, high
difficult.
BMI patient, yes.
Yeah, yeah. So, and sometimes it is what we describe the triple P procedure, no? So for that, placental mapping, especially the depth of invasion. Okay, so that is one more indication where MRI is, important as far as, or rather, I would say superior over ultrasonography. Otherwise, given the choice, a good resolution ultrasonography and an expert sonologist is good enough for the diagnosis of placenta accreta spectrum.
And actually, this has to be inculcated in the minds of all the obstetricians that whenever they are doing a growth scan or an anomaly scan, specifically placenta has to be looked and PAS has to be ruled out. Because diagnosing PAS when it's very obvious with all its big lacunae and turbulent blood flow in the color Doppler, I think even a not so expert obstetrician, if he has the eyes for it, can diagnose it.
The eyes see only if the mind knows about it.
Yes,
okay.
yes.
So that is why we should always keep a high index of suspicion. These are just the ultrasound, findings, what characteristics it can have. So everybody knows it. What special precautions during surgery we have already discussed, and that is how I think this should be enough for the placenta accreta spectrum. So now we have this fourth case. We have this 20-year-old young primary gravida, 9 months Amina. She is referred to the tertiary care hospital from a nearby small nursing home. She was in labor there for almost 8 hours and she was not progressing. So they decided to go for cesarean section. The sister catheterized the bladder and she found that absolutely no urine. Retrospectively, she inquired that even for last 8 to 12 hours, she did not pass any drop of urine also. So when you examine, you find that, the pulse rate is high, 110 almost, blood pressure is 110/70. The uterine contractions are plus. That means very severe in intensity. There is no relaxation in between. And the fetal heart is only 120. I'm sorry for this dilatation. It's only 2 centimeter dilated. Membranes are absent, not 7, but membranes are absent. Station is 0. So what is your diagnosis for this patient? What is your diagnosis for this patient? And also membranes are ruptured and there is a blackish discharge, black colored blood stain discharge.
I would definitely put out this diagnosis as abruptio placentae. Again, I would go for the labor room USG. This is also important, very important nowadays. And labor room confirm the diagnosis. Here, pulse rate is, almost tachycardia is there, but the BP is not favoring somehow what diagnosis mostly abruptio placenta is.
I would say deceiving, not favoring also, but the BP is deceiving you, misguiding you.
Yes,
okay?
yes.
Yeah. So it is so that, the BP may be high. That's why she's landed up into abruptio. And now that her blood pressure is
the fall of the blood
relative hypotension, right?
Yes.
Okay. So once we got the confirmation on ultrasonography, then she was sent, her investigations were done. HP was only 8 gram%, platelets 1.5 lakhs, PT INR was 2 and FPTT was prolonged, fibrinogen was only 150 and FDP was present. Now what is your diagnosis and how would you manage this patient?
Abruptio placenta with renal failure with DIC. DIC is the final diagnosis.
Right.
As soon as possible, patient is stabilized hemodynamically. We should refer this case to super specialty, multi-specialty hospital where dialysis is possible, where hematologist is
Massive transfusion
available.
required for that, multiple platelets, multiple FP, and which to correct her DIC. And
FFP.
Dr. Sujat, is it not so that, it may be just the acute renal failure, she will not she may not require any dialysis, because she, if at all we try to resuscitate her aggressively, the aggressive fluid resuscitation, correct her hypovolemia, that will improve her renal perfusion, and we are trying to prevent her to going into irreversible renal failure, right? So in fact, rather than referring, all of referring this patient will worsen her, prognosis, not only fetal death, but even maternal mortality, right? So
I
if
just
you
said, patient condition can
whenever
improve within 3-4 hours. So if
whenever
you infuse, we transfuse RBC as well as FFP and cryoprecipitate. And in spite of it, if condition is not improving within 4 hours, I think we should refer the patient, because condition can go either side. It can improve, it can worsen also.
by the time leak is developed, mostly the fetus is died. Whatever my experience is that even the book also said by the time leak has been developed, the fetus already died. Full-term fetus died. That might be
not always so, because how does the coagulation cascade starts? It is with a little separation of the placenta. So it may be just a little separation of the placenta that has initiated the coagulation cascade. Okay, but the bleeding is not so severe. That is why the fetus is alive. Okay, and that is why she has not gone into very drastic hypertension also. It's not always the dead fetus which leads to DIC, or the profuse bleeding that leads to fetal death. Here the fetus is alive. So in fact, my next question is whether you want to take her up for cesarean section immediately, or you want to arrange for blood and blood products. Yes.
4 plus 4 plus 4. We have to manage the massive blood and blood products for that.
Yes,
we
but
have
my question is, my question is whether you want to take her up for cesarean section first, or you want to arrange the blood and blood components and give her and stabilize her.
Both the things should go side by side. You go for a cesarean. You go for a cesarean section. By the time they get the blood products, infuse it. And before you take her for cesarean section, in this case, again, you have to take the consent that you may have to go for stepwise revascularization. You may have to go for cesarean hysterectomy also.
Because there is an acute renal failure that might lead to maternal comorbidity also.
Acute renal failure is reversible, no? Acute renal failure is reversible. Once you correct the hypovolemia, give Lasix, that is the forced diuresis, that itself takes care of. That is what I'm saying.
Blood products are not available. After proper counseling, we can take her for cesarean section before we get blood products. Because to save the baby.
I don't think so. We should never risk the mother.
We have to manage cryoprecipitate also, even if it is available. Nowadays, factor 7 is also available.
Yes, perfect. So the ideal answer, or rather the ideal solution to this situation is you arrange for blood and blood components, give factor 7 by the time you keep everything ready, take her up for cesarean section. So at least you make sure that you are getting the blood and blood components. Okay, and then you start infusing her at least 1 or 2 by the time before you start this. Otherwise, you may lose the mother. Okay, so that's the reason I asked you this question, whether you should take her up for cesarean section first. So these are the grades of abruptio placentae. We need not go into the theoretical details. The principles of management, as you have already said, that she is a case of abruptio placentae. She has gone into hypovolemia and then acute renal failure, and simultaneously she has gone into DIC, and of course there is a fetal distress. So all these problems you have to sort out. But you don't have to infuse only the fluids. You have to see that you are maintaining the hematocrit and electrolytes coagulation factor also. So that's the reason you have to give all these fluids also, and you have to stabilize the mother before taking her for cesarean section. If at all she is bleeding profusely, then only the condition that, either ways you have a problem. That is how you have to counsel the patient and relatives, and then take an informed written consent. So either ways you have a risk, so might as well try this. Get rid of this bleeding placenta so that, we can go ahead with the management further. So this is all. Do we want to talk about this DIC? Anybody can take up. How much, if the fibrinogen is 150, how many FFP or cryoprecipitate you need? All of you know this, because you all are saying that, FFP and pack cells, you give 1:1. Okay.
-1. That is
yes. Yeah. So if you have cryoprecipitate also, that you may go
10 to
ahead.
15, at least we give 10 to 15.
Yes. Platelet is good enough here, but then it rapidly declines the platelet counts with further clots, right? So initially it was good. So I think we should stop here. I think we should stop here with the discussion. I have so many good cases also here, but I just take this opportunity to thank all of you and the entire Gujarat
that
state.
I'm suffering from toxoplasmosis, and therefore I was advised to avoid pregnancy, and I was given treatment with sparomycin.
Okay. So I take this opportunity to humbly seek your blessings for my candidature as FOXI Vice President. I would just share my journey in short. Basically, I am a practicing obstetrician gynecologist since last 28 years. And before this, for 5 years, I was a assistant professor in Government Medical College. So total 33 years of my experience. After celebrating the silver jubilee of my practice, being at the top of my city, being as a reputed obstetrician gynecologist, I was invited as national faculty since 2000 in all the FOXI conferences. So like all of you are, invited. I was also told that you are such a good faculty and of course a good leader. You can come ahead in FOXI, and that is how I joined FOXI. And actively since now almost 2017, I'm going ahead actively in the organization. I got elected as a FOXI committee chairperson in 2018. So 19 to 22, I worked as a FOXI breast committee chairperson. And of course, I got elected as governing council member, which was also the toughest election which I won with the maximum margin. And about the awards, all of you know that I have got many national individual awards from our fraternity FOXI, and of course lots of awards from ICOG also. So I have got a Healthcare Excellence Award for my obstetric career, so academic and professional excellence. So with this, I would like to go ahead in FOXI as Vice President with all of your blessings and support. So once again, I humbly seek your blessings and support from all of you. I thank you all for your active participation. Very learned panelists, I would say. I too enjoyed discussion of all the cases along with you. And thank you so much once again, all the society president, secretaries, and all the panelists and chairperson. My special thanks to Archana and Dr. Munjal, Dr. Kirtan, and Dr. Sarfaraz Kazi. Thank you, all of you.
Person, and I think we all should support Madam, and best wishes for your future endeavor. Looking forward the future VP here with us.
Thank
you. Yes.
Thank you.
Kirtan, would you like to say?
Yes. So thank you very much, Madam Sneha, Madam. As usual, this was one of the wonderful academic sessions, and the talk by Dr. Mahesh Gupta sir was par excellence, and inputs by all the senior faculties, all the experts were quite useful to all the listeners, I must say. And in panel discussion, we did have your expert case scenarios, and we had so many senior colleagues and friends as panelists, and all of them have provided us with so many wonderful inputs. So to conclude, we as organizers thank all of you, all the senior faculties, colleagues, all the chief guests and guest of honor, and the expert faculties. And not to forget our dear friends, Dr. Sarfaraz Kazi, Dr. Munjal Pandya, and Dr. Archana Dwivedi Madam also, who is also contesting for the post of chairperson of Midlife Management Committee. So all the best, Madam, to you also and to Sneha Madam. And we all are sure for your victory. And all the votes from the presidents and secretaries from Gujarat societies would definitely go ahead with you for the nomination, first of all, and thereafter for the actual election process, madam. We assure you that. So all the best wishes to all of you and thankful to all the faculties who have participated.
Thank you so much. For the Vice President, I request everybody's vote, as every Foxians members need to vote. So every vote counts for me. So I request all of you, everybody personally. Thank you so much. Thank you, Dr. Falguni, Palak, Pinky, Dr. Ashok Patel, and of course, Dr. Shilpi and Dr. Sujatwali. Thank you, all the panelists. Thank you so much.
And also, Ms. Sahiti, who is providing us with this wonderful platform for connecting all of us together.
Always, Sahiti. Thank you so much.
Thank you,
Thank you.
Ketan.
Thank
Thank you, Sneha ma'am, and the whole team of panelists. We had a great time together. So let's, these all take-home messages remain with us for practical obstetric problems which we'll be facing in day-to-day life.
Yes.
Thank you, Sneha ma'am, for making us aware in a very simple manner the way we can follow daily. So I think we'll sign off with good memories and looking forward to another session soon. Thank